Good afternoon. Thank you again for taking the time to attend this press briefing on Haiti. Haiti's cholera epidemic continues to spread and produce more cases. As of this morning, the Ministry of Health is reporting 4,147 new cases of cholera and 292 deaths. Departments reporting cases include Arbanite, Central, and West departments. Suspect cases are also being reported in the departments of Nord, Northwest, and Northeast. As I emphasized on Monday's press conference, you will hear different reports from different sources. The data I'm reporting come officially from the Ministry of Health in Port-au-Prince as of this morning. Today I would like to focus my remarks on the national strategy to respond to the cholera epidemic in Haiti, and which will guide the actions of the Ministry of Health and its partners, including PAHO, in responding to this cholera epidemic. The Ministry of Health presented this strategy to all the international partners in Haiti, including the United Nations representatives and several NGOs, non-governmental organizations, and bilateral organizations. The strategy prioritizes three important measures: to protect families at the community level, to strengthen the primary health care centers already operating across the nation, and is to establish a network of cholera treatment centers and designated hospitals for the treatment of severe cases. So in summary, the strategy is aimed at minimizing the number of cases or preventing the number of cases, and then as well, once infections occur, minimizing deaths. To provide protection for families, health officials and partners are continuing to distribute the oral rehydration salts, these life-saving salts, directly to the communities. These have been developed and used over the past decades that have saved millions of children's lives around the world in developing countries. This simple treatment can be administered at home and is usually adequate and prevent the complications of about 80% of the cases that occur. The strategy also calls for disseminating messages over the radio and TV, via community health workers and leaders, and over loudspeakers mounted on trucks and other vehicles. The community-based messages encourage hand washing, sanitation measures such as proper management of human feces and garbage, purification of the drinking water by boiling or using the chlorinated tablets, and eating only cooked foods or peeled foods. The messages also describe how to prepare oral rehydration salts and how to care for cholera patients safely in the home and when to take them to the health facility. The Ministry of Health is also sending community health aides into the poor and densely populated areas, including the temporary settlement areas that were created in response to the earthquake. And they are working to actively seek out and refer the sicker people to the cholera treatment centers, while at the same time giving them the first dose of the oral rehydration salts. They will also supervise the measures in the local community and neighborhoods to ensure clean drinking water, proper waste disposal, and maintenance of latrines is being done. More than 60 community health aides are in the process of being deployed to the temporary settlement camps that were set up after the earthquake. The community health aides are intended to support and complement the many Red Cross community health workers that are already working on the ground there. The ministry will also be establishing a network of community health posts, and the idea here is to target one post for every 25 families. And this post will have the capacity to treat diarrhea cases and provide information on prevention and management. So the overall strategy is aimed at strengthening the primary health care network across the country and provide 24/7 coverage. build new structures in addition to the 33 designated hospitals nationwide that will serve as cholera treatment centers for the most severe cases. Assessments have already been done in 8 of those hospitals to determine what they need in support to this action. To support the Ministry of Health's planning efforts and also the Dominican Republic's contingency planning, PAHO has been working with the Centers for Disease Control and Prevention to develop projection of cases, estimate of cases based on different modeling scenarios. This information will help us with planning purposes in response to the outbreak. It is impossible, however, to predict the course of the epidemic, even with the best modeling. PAHO and CDC experts are also working together to improve surveillance and reporting of cases, analysis of water samples from the rivers and other sources of water to determine if they're contaminated, monitoring of antibiotic resistance, and the development of clinical management guidelines. For example, how to treat adults, children, and pregnant women. You will find this updated information on PAHO's website, www.paho.org. I'll stop there and answer any questions that you may have. Thanks again.
Thanks, Dr. Andrews. Do we have any questions from people in the room? Okay, and then we'll look for some electronic questions. We have one from Val Willingham at CNN at Turner Network News, which is about the prevalence of cholera worldwide. Is cholera endemic in many parts of the world, and is this an unusual event for the Americas?
It's a good question. Cholera is endemic in many parts of South Asia, for example, parts of India and Bangladesh. It's also endemic in many parts of sub-Saharan Africa. It's unusual for the Americas. Our last cholera epidemic occurred in 1991. Prior to that, cholera had not been reported in recent years. So with the 1991 epidemic, we saw rapid spread of transmission in, at the time, a very naive population in terms of population immunity. And at that time, I'm told that one of the indicators for monitoring spread was an indicator demonstrating the number of new countries infected per week. So it spread rapidly throughout the region from Argentina to Canada. Places like Montreal and New York City also had cases. However, transmission was controlled. We had sporadic outbreaks. And interestingly enough, Haiti and other countries of the Caribbean did not have cases. So Haiti's population is totally naive in terms of population immunity and protection to any introduction of the bacteria into its community. And so we expect, as we're seeing now, a very rapid, very explosive outbreak with a very steep epidemic curve.
And then we have a question from Betsy McKay at the Wall Street Journal, who says, many organizations are providing clean water and helping now with sanitation. Long term, though, can Haiti prevent cholera epidemics given current levels of sanitation and access to clean water in the country? If not, what needs to be done to improve them?
It's a great question. It really lends itself to discussing the long-term plan for capacity development. It's all about the capacity of the Haitian national government as well as the local authorities to provide safe water and sanitation facilities to their communities. We think that if the response is grounded in a long-term vision, we have the opportunity to really make a difference with regards to the issue this question brings up. Our experience with the 1991 outbreak is that even with such a rapid and very large, extensive response in terms of deployment of teams, experts, and so on, that the outbreak will take some months to try, some months to turn the tide. And then we'll come down to lower levels with continued transmission. And in the case of Peru and many of the other countries of the hemisphere, they saw cases for a couple of years after the start of the outbreak. So in the case of Haiti, we expect that this will not go away in the next few weeks. We will be confronted with cholera cases over the next several years that will require a long-term plan of capacity development that will respond and provide the services I mentioned, but also the surveillance capacity to monitor cases and detect any increased number of cases that would put public health authorities on the alert.
Okay, thanks, Dr. Anderson. And then we have another question from Blake Schmidt, the Bloomberg News reporter for Central America, in the Caribbean, I guess, who asks, has the epidemic peaked, and is there any evidence that it originated from MINUSTA officials from Nepal?
The question of when the epidemic peaks is a difficult question to answer while you're immersed in the outbreak response. And the reason is that although we're working very hard to strengthen the surveillance to provide the most accurate real-time data on a day-to-day basis, we really don't know about those communities where diarrhea is occurring but never reach the health center where that would trigger an investigation and reporting response that allows us to monitor more accurately the number of cases. So, in other words, cases are occurring in the community that we don't know about, that never reach treatment in a health center, which is good if it's adequately managed by a family, as I mentioned in my speech. But that, and there are also, we suspect there are probably many deaths that are not being reported in the community as well. So it lends itself to a situation where you will always have some underreporting of the situation, and in that case then it's really hard to determine at any point in time while you're involved with this if the outbreak is being turned around. Usually it's an analysis in retrospect where you see the downswing of cases after a period of time. I hope that addresses the question. The other part about the source of the outbreak is a question that comes up on a daily basis. We get several questions. Where did this bacteria come from? And we really won't know the answer to that question until molecular analysis is done on some of the isolates that have been identified from cases in Haiti. But you know, that's an interesting question that we may never know the answer to, because we know that there are sporadic cases in Louisiana, for example. Over the years, even a state like, or a place like Louisiana will have some cholera cases because cholera exists in the Caribbean. So we're doing our best to try to determine that, but right now we don't know the definitive answer.
Okay, thanks, Dr. Anderson. Then we have Richard Knox from the Science Desk at National Public Radio, who asks if you can tell us about the current pace of new cases and deaths, not just current totals. What picture does this paint? Is it stabilizing?
I don't personally, given the data we see and analyze, it doesn't appear to be stabilizing. It appears that when you track cases and plot them on a timeline, we call that an epidemic curve. Now, epidemic curves can go very slow and trickle along as such with some diseases, particularly chronic diseases. But in a disease like this that is so highly infectious, what you see is a rapid upswing in the number of cases over a short period of time, and that's why the slope of the curve is so steep. And that's what we're actually seeing. Now, to say when that outbreak is being tempered or being turned around is difficult, given what I said about the underreporting, about the number of cases occurring in the community that never reach the health centers and so on. We can monitor severity by keeping track of the number of hospitalizations, and once we see a reduction in the number of hospitalizations and the deaths that occur as a result of hospitalization, those may be preliminary signals that our efforts are indeed making a difference.
Okay, and Richard Knox still has two other questions, which are, one, with respect to the origin of new cases, are they still mostly from the Artibonite department? Have there been more reported in Port-au-Prince than the 5 previously confirmed?
Yes.
And also, what do we know about the in-migration of people from affected areas to Port-au-Prince? We've reported tracking of people via cell phones. Is there concern about stemming this route of potential infection?
Many parts of that question. I'll do my best by starting with the first part, where on the map behind me, you see the river from St. Mark that goes inland in the colored area of the province of Arbanite. You see that river extend inland in Haiti. That's the river that's implicated with many of these cases, and most of the cases are geographically clustered in that area, that river basin area. And there are many tributaries to that river and many valleys, and so it provides a challenge to adequately track and follow cases. But that seems to be the descriptive epidemiologic picture right now, the location along that river basin. Now certainly in Haiti there's lots of migration within country as well as out of country, as well as across the border with its island neighbor, the Dominican Republic. Fortunately, we have not seen or heard of any confirmation of cases in Dominican Republic. Does that mean we do not expect cases in the Dominican Republic? And in fact, we do expect cases. And so to that end, PAHO and partners have sent teams to help the Dominican Republic prepare and plan for possible cases. But the traffic that goes to Port-au-Prince is an important consideration and puts those vulnerable populations at risk. You know, remember that there's a substantial fraction of cholera infections among people that go asymptomatic. So even an asymptomatic carrier can shed the bacteria, perhaps contaminate a water source that's ingested by a vulnerable community, and then you'll have the start of a local outbreak, or spread of the epidemic that we're seeing in the Arbanite area, which indeed has spread to other provinces that I mentioned at the beginning.
I think we have what I think is the last question from Honduras, which is, should we be taking extreme precautionary and preventive measures in Honduras and in other countries which are somewhat removed from Haiti with respect to cholera?
It's a great question. I can only cite again the example of the 1991 epidemic that spread across the Western Hemisphere. And I would advise that countries be on the alert, monitor carefully the reporting of diarrhea cases, and strengthen their water and sanitation services. This is an excellent time to do so in advance to the risk of spread of this outbreak. I'll mention once again that one of the indicators that monitored the 1991 outbreak was the number of new countries that became infected, so over 1 week's period of time. So that just shows you how rapidly this can spread. And if we're on our guard, we can do mitigating interventions that will help prevent the spread and establishment of infection in any one particular country.
All right, are there any other questions, either on the line or electronically or from people in this room? Sir, please go ahead. If you could identify yourself, please. Speak into the mic. Somebody over here.
Yeah, hello, good afternoon, Dr. Andrews. My name is Conor Giacottini. I'm from Delpac. I just wanted to ask a very important question. I think my question is that don't you think that the United States has a moral and humane obligation to alleviate the suffering of people in Haiti by making sure that the military, especially the Army Corps of Engineers, should be deployed immediately with sanitation, sewage systems, and also specific medications in order to alleviate the suffering. Because as you may well know, Mr. Luch already indicated that the Obama administration had, since January of this year, to evacuate the millions of Haitians from Port-au-Prince to other areas of Highland, and this wasn't done. Don't you think, as of now, since this is becoming a very serious epidemic crisis, that the United States should deploy the military right now to organize and also help in conjunction with the State Department to make sure that this cholera outbreak doesn't become much worse? Thank you.
Thank you for the question. Let me summarize several points in terms of how the response is being coordinated. First of all, we're very fortunate in the Americas to have an inter-American system that PAHO is a part of, the Organization of American States, and the other mechanisms that allow countries to help each other, with the guiding principle of increasing capacity of the local response while ensuring equity and access to health. That's really, when you mention the word Pan-Americanism, that really defines the approach, where countries that have the resources help those that do not. And that's really how the Pan American Health Organization was founded back in 1902. Now, with this most recent crisis, we at PAHO have been managing what Canada can do through several coordinated calls, whereby we have a conference call with all the Canadian entities, Public Health Canada, Health Canada, several other, CEDA Canada, and that purpose of the call is to make more efficient the coordination and share information. It's a great way to strengthen coordination, and similarly we do that with our U.S. colleagues. So we have a conference call on a regular basis that includes representatives from the Health and Human Services, from the State Department, from NIH, from FDA, from CDC, all those entities within the U.S. government system, even Southern Command, USAID, that are involved with the response. So it's a great way, again, like with the Canadian example, to coordinate the response, share information, and at the end of the day, not duplicate or waste resources. But the Inter-American system allows PAHO to use the expertise from Brazil. Brazil has sent chlorinated materials to country. They're deploying teams, as have the Cubans, as have a number of other countries. It's very similar to the response with the earthquake. And I think we believe that no one country should have the ultimate responsibility. This should be a regional approach involving all the countries, because that's Pan-Americanism, and allows us to, in the future, have the capacity to even do a better job. And it really feeds into the spirit of cooperation, the camaraderie, the spirit of core of all the countries working together towards a common goal to help the poorest country in our region get through this crisis.
Okay, thanks. And then we'll make this one the final question, Dr. Anders, because I know you have to go brief the OAS Friends of Haiti group immediately after this. Richard Knox from NPR again asks, is there any rationale for or any consideration of using cholera vaccination, perhaps for targeted populations around new outbreaks? Would this be feasible, and has ring vaccination ever been tried in cholera outbreaks?
I'll start with the second part of that question, because that brings up the experience of smallpox eradication, whereby if you have a disease where there's a one-to-one correlation with the clinical presentation and the actual number of infections in a community, then, and the epidemiology of that disease is such that you could do ring vaccination. In other words, it doesn't spread so rapidly that once you organize your teams, the horse is out of the barn. So in the case of smallpox, that was a model example of how you could target with good surveillance a case, knowing there were no asymptomatic carriers, that represented where infection was, and you could do the ring vaccination. Now with cholera, similar to polio, you have asymptomatic carriers. So you can't determine with any accuracy where that bacterium is circulating, because it could be everywhere if you have asymptomatic carriers. So to do ring vaccination, you've already, that analogy, the horse is out of the barn, you already have transmission outside your ring. And the whole idea with the ring is to define an area where you stop transmission. So it makes it very, very, very difficult. The vaccine is not recommended during an outbreak, and there are a number of reasons why. It requires 2 doses, and in children less than, I think it's less than 2 years or 3 years, 4 years of age, it actually requires a 3rd dose, one of the vaccines. There are only 2 oral cholera vaccines available, one of which is pre-qualified by WHO, meaning that we can purchase it, the revolving fund that PAHO manages for procurement of vaccines for countries of the Americas. We can purchase it because pre-qualification assures safety of the vaccine. If we don't have that, then we don't really have the WHO stamp of safety, so we need that. There's another vaccine, but before I get to the other vaccine, this vaccine I'm talking about that's pre-qualified, there are limited doses available. So in a country of, say, 10 million people, or the city of the size of Port-au-Prince, if you're talking about vaccinating and you only have a couple of 100,000 doses, you really don't have an adequate response. It's basically an academic exercise. If there was a supply from the other vaccine, which we were trying to find out and determine, there may be a role for what we call preemptive vaccination, and I'll get back to that. But this other vaccine is not pre-qualified, so it raises questions: do we really have the necessary information in place that we can be assured this vaccine is safe? And that's always an issue with vaccination. Be sure we do no harm, that it's safe, and that WHO mechanism helps reassure us of that. But the preemptive vaccination, so to repeat, to vaccinate during an outbreak with a vaccine that requires multiple doses, requires mobilization of vaccinating teams, resources, training, that would not confer immunity for perhaps 3 weeks at the soonest, knowing how fast this epidemic is spreading, and knowing that the attention should be put on prevention, safe water sanitation, those measures I mentioned, and minimizing deaths, the rapid treatment of severe cases. We don't want to divert attention from those measures. So that's why vaccination during the outbreak itself is not recommended. So the question becomes, well, are there populations where the outbreak has not reached, and would it be useful to vaccinate those populations in a preemptive fashion? That is a consideration. We're having technical discussions about that. But again, the critical issue is whether or not there's sufficient doses. And at the moment, the information we have doesn't lead us to believe there are. So it's something that we're entertaining. And finally, I'd just like to say that the measures to prevent and treat this disease are so effective. So to prevent frequent hand washing, sanitation, that we don't vaccinate our own staff that are working there on the ground, nor do we vaccinate any staff that we're sending there, deploying to the ground. Nor do we vaccinate the health workers who are treating patients on a minute-to-minute basis. As long as they wash their hands between patients, as is the standard of care, there's really no evidence to suggest they are going to get infected or contribute to the spread of infection. I think that sort of sets the stage about how we developed this recommendation. Keep focused on prevention and treatment. Perhaps consider the preemptive measures if there were supply, but right now we just don't have sufficient information. I'll stop there. I hope that answers the question.